So, AP 120, Chapter 17, topics tubular reabsorption and tubular secretion. Before I go into that, I just want to go back to the previous lecture. I had been talking about angiotensin II and its overall effects on the blood and on the urine, and how it leads to an increase in blood pressure by vasoconstriction, by stimulating the release of hormones that will make urine more concentrated, so we're conserving water for the blood, and also increasing thirst. So increasing blood volume by making you thirsty, you drink more water, that will increase blood volume. I didn't get to talk about this hormone though. The heart is able to secrete the hormone atrial natriuretic peptide. This hormone is secreted when blood volume is high. High blood volume equals high blood pressure equals a lot of work for the heart. So it secretes this hormone that goes to the kidneys, goes to the nephrons, and stimulates the excretion of sodium into the urine. So there's more sodium going into the urine. Water follows sodium, so now there's more water going into the urine, so we get dilute urine. This then decreases overall blood volume, which would then decrease overall blood pressure and make the heart happy. Isn't that weird? The heart can make us pee more. All right. Tubular reabsorption. Tubular reabsorption is returning materials, returning fluids to the bloodstream, returning them to the peritubular capillaries. So most of this occurs in the proximal convoluted tubule, a little bit in the nephron loop, but mostly in the proximal convoluted tubule. The cells lining the proximal convoluted tubule are designed for this process. They have microvilli, little processes sticking out into the space of the proximal convoluted tubule, increasing surface area, so increasing absorption, movement of materials through the walls of the proximal convoluted tubule. There are also carrier proteins in the microvilli. These proteins are going to help move things like nutrients, like glucose, to get it back to the bloodstream, because that's an important nutrient. However, there is only so many carrier proteins able to transport glucose. So in people who have trouble regulating glucose levels, say people who are diabetic, they might have extremely high levels of glucose in the blood, which means high levels in the filtrate, which means that some of that glucose is going to be lost in urine. All right, so normally tubular reabsorption, the first thing that's happening is sodium ions are being returned to the bloodstream, returned to the peritubular capillaries. Via active transport, energy is moving sodium back into the bloodstream. This will then cause negative ions to return to the bloodstream because it'll be a positively charged environment in the peritubular capillaries, so negative ions will want to travel via passive transport back to the bloodstream. And then also water will return to the bloodstream. The blood is now becoming hypertonic because of all these electrolytes, so water will move from high concentration of water to low concentration in the peritubular capillaries. And it turns out most of the water, over 90% of the water, will return to the bloodstream. Now, we also want to fine-tune the composition of the blood. So there's a process of tubular secretion. This occurs primarily in the distal convoluted tubule, a little bit in the collecting duct, but primarily in the distal convoluted tubule. Now we're moving materials from the blood in the peritubular capillaries back into the filtrate in the distal convoluted tubule. So via active transport using energy, we are moving hydrogen ions back into the filtrate and also potassium ions. Hydrogen ions are very important because our blood has a tendency to become more acidic. And so by moving the hydrogen ions back into the filtrate, we're able to excrete the excess hydrogen ions, lowering or raising the overall pH in the blood. And then potassium ions, if there's a significant amount of potassium ions in the bloodstream, then they are waste, and so we're removing them as well. Also, other things, organic compounds, drugs, medicines, toxins, and so on, can be sent out of the bloodstream into the filtrate that eventually becomes urine. So the final composition of urine is extremely different from what we had in the blood plasma and in the glomerular filtrate. Sodium concentration goes down a little bit, but potassium concentration dramatically is higher. Chloride composition's higher. Other electrolytes composition changes. And as we can see, there should be 0 glucose in the urine and a dramatic increase in the wastes, urea and uric acid. So urine's composition is distinct, with the goal of getting rid of wastes and conserving important nutrients. All right, hormones help to regulate urine concentration. Aldosterone, we mentioned a little bit already. Aldosterone stimulates the distal convoluted tubules to reabsorb sodium ions. So again, most of the reabsorption occurs in the proximal convoluted tubule, but this hormone, aldosterone, causes reabsorption in the distal convoluted tubules. Sodium returns to the bloodstream, so water will follow via osmosis. This leads to more concentrated urine. Also, in the process, more potassium ions are secreted because, again, we don't want potassium ions in the bloodstream, at least not very much. Then there's also the antidiuretic hormone produced by the posterior pituitary gland. Antidiuretic hormone increases the renal tubule's permeability to water, and therefore water is reabsorbed. So antidiuretic hormone increases the reabsorption of water, making the urine more concentrated. So, how this works, we get a concentration of water in blood decreases, so blood volume is going down. This increases overall osmotic pressures, causing the brain to say, wait a minute, I don't want a concentrated blood or concentrated cerebral spinal fluid, so it sends signals to release the hormone, antidiuretic hormone, goes into the bloodstream, reaches the kidneys, and then it will cause the distal convoluted tubules and collecting duct to increase water reabsorption. Again, normally this doesn't happen in distal convoluted tubule or collecting duct, but antidiuretic hormone causes water to be reabsorbed, returned to the bloodstream, causing very concentrated urine. And this helps to slow down the loss of water and to try to keep the blood volume up. It doesn't raise the blood pressure or blood volume, it's just trying to prevent it from going down significantly. Then, of course, we have that hormone I mentioned earlier, atrial natriuretic peptide, which has the opposite effect. The heart says, wait a minute, blood volume, blood pressure is getting too high. It releases its hormone that goes to the kidneys and stimulates sodium excretion by the distal convoluted tubule. Again, normally not occurring in the distal convoluted tubule, but now it is. Sodium is being returned to the filtrate, and so water is following and being returned to the filtrate, leading to more dilute urine, lowering blood volume, lowering blood pressure. So what do you do if the blood pressure is too low versus what happens if blood pressure is too high? Kidneys and urine are involved. All right, urine composition is mostly water. Shouldn't be a surprise, and some solutes. And this is important for maintaining proper homeostasis. So urine, again, mostly water, and a lot of urea and uric acid, sometimes some amino acids, and other electrolytes, obviously other electrolytes. But urea is the big waste that we're getting rid of. Overall volume of urine produced should be somewhere between 0.6 and 2.5 liters per day. Much, much less than the starting 180 liters of filtrate that are produced per day. And things that you should not find in urine: glucose, proteins, ketones, blood cells. So if they're present, that can be a problem. And to know if you are hydrated, to know if you're producing enough urine, you just check the color of your urine. If it's dilute in color, the clearer it is, the better. You are hydrated. If it's darker in color, then you are dehydrated. You need to consume more fluids. And if it's really, really dark, you might need to go to the hospital. Disorders of the kidneys. Well, there's renal failure. That's a decrease or cessation of glomerular filtration. So the nephrons are not producing the filtrate. So now the kidneys are no longer able to function. This can be acute, which means short term, can be caused by some low blood volume. The heart is decreased in function, kidney stones, drug effects. But acute means short term, so it should hopefully return to normal. Chronic renal failure, on the other hand, is progressive and irreversible. Over time, more and more nephrons are losing the ability to produce filtrate and so no longer function. Eventually, it'll get severe enough that the person will need to go on dialysis. This is using a machine to cleanse the blood to return it to an ideal levels. The person ends up having to go to a dialysis center, say 3-4 times a week, and spend 3-4 hours on the machine. Not an ideal setup. And people on dialysis are, of course, hoping to get a kidney transplant, where you take a kidney from a donor and place it into the patient, and then that new kidney will function properly, hopefully, and allow the person to have normal kidney function for the rest of their life, hopefully. The one interesting thing about kidney transplants is you can have a living donor donate a kidney, because a person can survive on just one kidney. However, you have to make sure that it is a good match, because you do not want the kidney to be rejected, because then the person who received the kidney will have to go back on dialysis, as well as having that rejected kidney removed, and it's a waste of a very good organ. And that is it for this part of the lecture.